Hello and welcome to this channel. My name is Victoria and today we're going to talk about a dermatology related topic, which is dermatitis. Dermatitis in general is a very vague term describing all kinds of skin irritation. It is a very common condition, but it presents itself with many different causes and clinical appearances. One feature all forms have in common is that the skin is generally dry, itchy, and usually reddened, and it often flakes off. The first form of dermatitis I want to talk about is the contact dermatitis. It is caused by contact to an irritant, which can be soaps, cosmetic, fragrances, jewelry, plants, but also more aggressive chemicals like acids, drain cleaners, nail polish remover, paint, and even body fluids like urine and saliva. It can be acute or chronic, and it is divided into two main types: the irritant contact dermatitis and the allergic contact dermatitis, both of which are presenting as an inflammatory reaction to a substance. The irritant contact dermatitis makes up approximately 80% of occupational cases of contact dermatitis, and it is caused by a direct local cytotoxic effect. In the acute irritant contact dermatitis, the skin reaction presents as a sharply localized erythema with vesicles and edematous papules or hemorrhagic blisters. Often the skin also presents with scaling or crusting, and the patients experience excessive itching, also called pruritus. The clinical course depends on a degree of sensibilization, penetration, and duration of contact to the irritating substance. In chronic irritant contact dermatitis, the patient is exposed to a milder substance, but in a repeated pattern. For example, this can be due to frequent washing of hands. The rash is usually diffuse but can be localized, and the skin presents with scaly patches and flakes. The allergic contact dermatitis makes up approximately 20% of cases of contact dermatitis, and it is also called allergic contact eczema, since it is an allergic skin reaction of type 4, the delayed type of hypersensitivity, which can occur 24 to 96 hours after contact to the irritant. The contact to the irritant can be direct or indirect. The indirect way is usually erogenic. Upon contact with the allergen, the T lymphocytes are sensibilized in an allergic person. If this person comes into contact with the allergen a second time, then the delayed type of sensitivity will lead to a skin reaction after usually 24 to 72 hours. The most important allergens are nickel, which is found in jewelry, bra clasps, glasses frames, pants buttons, and many more. Chrome salts, which are part of many construction materials and leather. Cobalt chloride, which is in cement and dyes. Naturally occurring substances used in cosmetics, rubber, glucocorticoids, and many more. In the acute form of allergic contact dermatitis, patients present with a high degree of sensibilization and a high degree of skin penetrance of the allergen, which leads to pruritus, vesicles, weeping, erythematous macules, and dissemination of vesicles. The reaction of the acute form can be divided into 4 stages. The stadium erythematosum et oedematosum, where the skin presents with red discoloration and edema. The next stage is stadium vesiculosum et bullosum, where the skin forms vesicles and bullae as a protective measure to prevent further damage, followed by stadium meditans and eventually stadium squamosum. The subacute form is characterized by a less severe sensibilization and penetration than the acute form, where the skin presents with eczematous scaly plaques, prurigo papules, edema, lichenification, erythema, and autosensitization. The chronic form of allergic contact dermatitis is the one with the least sensibilization and penetrance, and this form presents with dry eczema, lichenification, hyperkeratosis, and scaling of the skin. Most important for the improvement of the patient's condition is to avoid the contact with the allergen, given the patient's known which substance causes the reaction. Alkaline soaps and washing agents can reduce the oily film on the skin and so can worsen the symptoms. The skin should be cleaned with fattening creams and should be added natural oils. Treatment by medications is usually by topical usage of creams containing salicylic acid, uric acid, antibiotics, and glucocorticoids. Also, phototherapy and antihistamines can be used to help the patient. Gold standard for the diagnosis of allergic contact dermatitis is the patch testing, which helps to identify the allergen. In this diagnostic method, plasters containing a standardized variety of allergens is applied to the patient's back, where they might or might not cause a specific reaction, which will be evaluated in severity or degree of reaction by a dermatologist. The more severe the degree of sensibilization, the more severe the reaction of the skin will be. The next form of dermatitis I want to talk about is the atopic dermatitis, also called atopic eczema or neurodermatitis. It is one of the most common chronic inflammatory skin disorders. Approximately 10 to 15% of the population is affected by it. It is a form of pruritus chronic relapsing eczema and usually has its onset early in the patient's life. Often it improves during puberty, but sometimes it stays until far into adulthood or never disappears. The disease often presents as part of the Atopic Triad, which consists of atopic dermatitis, rhinitis, and asthma bronchiale. So patients experience often more than one of the components of these triads, or one of the disorders is expressed in earlier generations of this patient's family. The etiology of this disease is not entirely understood, but it is thought to have a genetic, immunologic, and allergologic component, which needs a trigger factor during infancy or early childhood to be expressed. The pathogenesis involves increased secretion of the Th2 cytokine, as well as interleukin-4 and interleukin-5. Also, the mutation in the filaggrin gene is thought to play a key role. Filaggrin is a group of proteins which is responsible for the keratinization of skin by keratinocytes and so has a structure-forming role in the epidermal layer of the skin. The skin of affected patients presents with a severe itching, dryness, and scaling. The distribution of the lesions is usually dependent of the age of the patients, which can be a help in diagnosing the disease. Infants usually experience the eczema on their face, scalp, and extensor sides of the extremities. Children usually have the rash in the antecubital and popliteal area, as well as in the neck, wrists, and ankles, and adults, if they still are affected, often have it on their hands as the only place. This, however, can vary from patient to patient. The disease is usually not experienced in a linear progression, but rather presents in exacerbations, which can be caused by a variety of over 1,000 recognized triggers, the most common of which are stress, cold weather, soaps and cosmetics, food products, especially citrus fruits, red wine and old cheese, textiles, especially synthetic fibers, perfumes and fragrances, excessive heat and wind. The diagnosis is done mainly by anamnesis of the patient himself, but also their family. Every history of rhinitis, asthma, other allergies, or atopic dermatitis is of importance. But also the investigation of skin lesions is important. However, the patient might have made the appointment at the time of exacerbation and might not experience the same degree of symptoms anymore at the point of the appointment. Objective diagnostic tools include the skin prick test and blood tests, where usually eosinophilia can be found, as well as an increase in the overall IgE levels. Patients are also often recommended to write a diary about what they eat, when they wash their clothes and bed sheets, what shower and facial products they use, how the weather was, and many factors more, and how they experience their symptoms on a subjective scale. The therapy is difficult. Patients are usually recommended to avoid trigger factors, which might be impossible in the case of weather or stress. Another way of helping patients experiencing mild symptoms is by low-dose topical glucocorticoids, calcineurin inhibitors, antiseptics, and phototherapy. In moderately severe cases, high-dose topical glucocorticoids and calcineurin inhibitors are used, as well as also antiseptics and phototherapy. Systemic glucocorticoids are only given in extreme exacerbations where the itching is intolerable. The aim of usage of fattening creams is to bind the water in the skin and reduce the degree of dehydration by the outer layers of the skin. These creams usually contain uric acid, paraffin, and glycerin. Complications, if the disease cannot be controlled, include keratoconus, where the cornea of the eye gradually becomes thinner and more into a cone shape, which can cause blurred vision and photosensitivity, as well as eyelid dermatitis and a generally increased risk of infections. The last form of dermatitis I will talk about is the seborrheic dermatitis, also called morbus una. It is a chronic eczema of the skin with yellowish, oily, scaly red patches, and it usually occurs in exacerbations and affects the areas of the skin with the highest concentration of sebaceous glands. It is divided into two groups by age of patients that are affected. The type 1 is the dermatitis seborrhoides infantum, and it is a self-limiting form which affects infants. The second form is the one affecting adults. It is presenting in a form severe enough that patients request treatment in approximately 3 to 10% of the population, and it is more frequent among males. The causative agents are not exactly understood, but one of the predisposing factors is an increase in the activity of the sebaceous glands in infants when they experience a sudden increase in androgens by the adrenal glands. Another factor is a higher concentration of bacteria and yeast fungi on the skin, as well as immunodeficiency disorders. As said before, it usually presents with a chronic recurrent course with exacerbations and remissions. Remissions are usually caused by sunlight, while worsening of the symptoms is usually induced by stress and cold weather. The lesions are orange-red or also gray-whitish and scaly and can be presenting as macules, papules, or patches. The lesions are usually well marginated. In infants, the most common forms are the cradle cap, affecting the head of the baby, or the napkin dermatitis, which is usually involving prolonged contact of the baby's skin to urine and feces-filled diapers, which makes the skin more prone to disruption due to friction. Adults often experience the rash on face, forehead, ears, and body folds. Diagnosis is usually obtained by clinical presentation. A skin sample can be taken for microbiological culture. Histopathologically, the seborrheic dermatitis only shows unclear evidence, like acanthosis of the epidermis with hyperkeratinosis, slight edema, and perivascular and lymphocytic infiltrate. Until today, the disease cannot be cured, but usually symptoms can be improved by avoidance of creams with a high fat content. Topical therapy includes shampoos and creams containing ketoconazole, clotrimazole, or cyclopirox. For short-term use, also glucocorticoids can be prescribed. That's it for this video. I hope you enjoyed it, and I would be very happy if you would subscribe to our channel. It would mean a lot to us. Thank you very much.